We invite everyone to the next session, session 5 today. This will be case scenario discussions by students. First, we have. I would like for the first case. I would like to introduce our moderators, Dr. Anand Vaishnav sir and PN Shailaja ma'am. Dr. Anand Vaishnav sir is senior consultant neurologist. He's from WINS Hospital, Vadodara. Shailaja madam is professor of neurology in charge of the comprehensive stroke program in Sri Chitra Hospital in Trivandrum. She's the past president of the ISA, honorary professor for the University of Lancashire in UK. Ma'am and sir, I would like to request you to kindly take over the session.
So, good afternoon. Thanks to Padma and Rohit for inviting me and Dr. Anand for this session. So we have been given a guidelines with regard to how the session should go. I hope, can I share the slide?
No, many people are online. So I just...
Yeah, Shailaja, you can share the slide.
So I would like to invite Dr. Bidhan Mandal from JIPMA Pondicherry.
Yes, ma'am.
Yes. So can we start?
No, sir,
Yes, ma'am.
So separately also Zoom
Okay.
link.
So what we will do is we'll go through the slides slowly. I think everybody keep your mic muted. So what we will do is we'll go through each of these slides and go through the case scenarios, and we will ask you questions of anybody else can also answer if Dr. Bidhan finds it difficult to answer the questions. So this is a 55-year-old gentleman who presented with recurrent episodes of transient left upper and lower limb sensory motor deficits. Each episode lasts for about 10 to 15 minutes. Patient had 3 similar episodes in the last 24 hours. He had a risk factors of diabetes mellitus for the last 10 years, not well controlled, and he's a chronic smoker. There is no history of any seizures, loss of consciousness, heart failure, or palpitation. So in detail, during the first episode, the patient woke up in the morning to go to the restroom, noticed paresthesia of the left upper limb, which gradually involved the left lower limb when he tried to get up from the toilet seat. While walking back to the bed, he noticed a dragging of his left foot and weakness of the left hand, which also gradually improved over 10 minutes. He did not take any medical advice for the same. He had 3 similar episodes in the same day. He came to the ER after the 3rd episode, which has resolved as per the patient, and patient reached the hospital. From the 3rd event, the patient reached the hospital in 2 hours. So over to Bidhan. What are the clinical possibilities when a patient presents with a weakness of one side and patient has had 3 episodes, similar episodes, and is coming to the emergency?
Yes, ma'am. The patient had 3 episodes of neurological deficit, which involved 10 to 15 minutes each day, and came to the hospital with after the 3rd episode, and each episode involving the same side, left upper limb and left lower limb. With
what are the possibilities you will consider in this presentation? Just tell the possibilities. 1, 2, 3.
Okay, ma'am. One will be, ma'am, TIA will be, ma'am, possibility.
Yes. So it's a transient ischemic attack.
Transient.
Okay. Any other possibilities you will consider? It's only a vascular event you will consider in this patient. So why do you say it is a transient ischemic attack?
Ma'am, it actually have a same-sided weakness with sensory and motor. It may be some.
So here, because it's a transient, I also agree with you. It's a transient ischemic attack, mostly because here is an abrupt onset. There is an abrupt onset of both sensory and motor deficits with a sudden recovery in this patient. So first event, we will always consider a vascular event. In addition, it was told that the patient was having a very slow paresthesia going from, because as you know, TIA, the major problem is it's mostly you're diagnosing from the history.
Yes,
So we do not know in this patient. So it's everything is from the history you are getting the information. So here is a symptom from paresthesia of the upper hand, then going to involve the lower limb. Would you consider any other possibility? Can it be a seizure phenomenon?
It,
So that
it
is the
can
next
be
thing which will go through your mind.
it can be a seizure, but as weakness negative phenomenon, ma'am, is there. So that's it is it can
One
be.
is, yes, when there is a marching of phenomenon, always you should consider seizure as a possibility. But as you rightly told, positive symptoms, when you have positive symptoms like this, we have to consider, if it's a positive symptom, you will consider it as a part of a seizure. But here it is a negative symptom, and hence most likely it is a transient ischemic attack. One more point you should always know is that what are the other mimickers of TIA which you may get when the patient comes to the emergency?
The patient is actually diabetes and uncontrolled diabetes that actually can cause some metabolic problems like
So
hyperosmolar.
yes, so most important, one important differential you should consider in a patient who is coming with a history of diabetes is whether it's a hypoglycemia. So they can exactly mimic a TIE.
Yeah.
So
Yes,
it's
ma'am.
very important to look at the blood sugar in this patient before you tell it is a TIE. Okay, so rest of the possibilities are less likely because the patient is fully conscious and
Yes, ma'am.
awake. Okay.
Yes, ma'am.
So coming to the examination, the patient had a blood pressure of 80, a pulse of 85 per minute regular, blood pressure of 198 per by 120 millimeters of mercury. The respiration and saturation was maintained and the blood sugar was 132. The cardiovascular system examination was normal. Coming to the neurological examination, the important findings were the patient had a mild dysarthria and a mild human facial palsy, with the rest of the examination being normal, suggesting that the patient has a NIHS score of 2.
Yes,
So now we want to know. So we have confirmed it is a TIA. We feel that the blood sugar is normal here. There is no hypoglycemia. You find it is most likely a TIA. Now you want to risk stratify this patient. And most importantly, the patient came within 2 hours and the NIHS is 2.
yes,
So here you want to risk stratify this patient. One consideration is with regard to the acute management of this patient. And if it you because the patient told the symptoms have completely recovered, but here the patient has got a minor deficit.
yes, ma'am.
So many a time differentiation of a TIA versus minor stroke becomes always difficult. If the patient is having very subtle symptoms, the patient may tell the patient has completely recovered, but once you examination, you may find that it is not a TIA, it's a minor stroke.
Yes, ma'am.
So what is the risk? How do you risk stratify this patient if
Yes,
you
ma'am.
consider it as a TIA?
First of all, it is a multiple episodes of TIA, so it looks like crescendo TIA, ma'am. And ABCD2 score, age wise, it was 56 years, so it's 0. B for blood pressure, it is more, so it will get 1. And C for unilateral weakness is there, so it will get 2. And duration is more than now 2 years, 2 hours over, but it persists, so it will get 2. And diabetes also it get 1. So the ABCD2 score it will be around 6 it will be, ma'am. This patient as it is more than 3, so it actually high risk TIA, ma'am. We'll admit the patient, ma'am. And first we'll do if we have MRI,
So
DWI.
you told that you will stratify depending on the ABCD2 score, where the age is 1, the weakness you have given, and the patient is persisting to have the deficit. So
Yes,
here
ma'am.
after examination, we find it is not a TIA, it is in fact a
It's a minor stroke. Minor stroke. Yes, yes, ma'am. It's minor stroke.
So
That's why.
here that because clinically it was told as a TIA, but examination you find many a time. So, but the risk stratification is the same for TIA or whether it is -2, the
-2.
future risk is the same.
Yes, ma'am.
So you feel that clinical criteria, according to that, patient is a high risk in the high risk category. Okay.
ma'am.
So how would you go about evaluating this patient? So the patient is within the time window of 2 hours. So how would you go about evaluating this patient? I think Dr. Anand, you can take over at this point.
Sure. So what, the question comes is, what imaging would you like to do? The options that we have, the options are there in your institution. And I think then I'll briefly discuss what if you are not at your institution. What would you suggest?
Sir, if I have MR diffusion, I'll go for MR diffusion, sir, because it's look like, sir, minor stroke, so I can get that diffusion restriction. Or if it is not there, I will do plain CT plus vascular MRA or vascular imaging, sir.
You are taking the patient to a diffusion weighted imaging if you have an MRI. So would you not get MRI along with MRA, both of intracranial as well as extracranial?
Yes, sir. MRI with MRA, sir. I told, sir.
Good. Okay. So can we move ahead? So I think we live in an environment in India where there are institutions like, Sri Chitra or Jipmer, where you have everything available. And then probably when you step out, you may go to a corporate hospital or an institution where everything is available, to another extreme where you may be out in Visakhapatnam practicing and it may not be available to a small private hospital that you go to. So we need to think of all the three possibilities. I think the most ideal, as you said, would be to get an MRI, with a diffusion weighted imaging to see whether you can see a fresh infarct. And along with that, absolutely want to look at vessels, both internal carotid, so neck as well as brain. That's number one. As against that, if you do not have an MRI with an MRI, or a lot of time, even in an institution, MRI takes a longer period to get done. It may be at the other end of the institution, then absolutely a CT with a CT angiogram to know that there is no cervical or intracranial, atherosclerotic disease.
Yes.
And the third possibility we always have to keep at the back of the mind. CT angiogram is going to take time, or MRI is not feasible or is going to take time. Then, as you just said, a plain CT. Because the most important thing at this moment you want to know is, this is a stroke. Clinically it's a stroke. Yes, DWI would be great, or CT or CT angiogram would be great, but absolutely a CT, CTA or MRI plus MRA, depending on where you are. So this is a plain CAT scan of the brain. And can you tell me what the CT scan shows?
There is a right-sided gray-white differentiation, probably, sir.
I would put it more in the gray zone category. I mean, I can see the caudate here. I can see the anterior limb, genuine posterior limb. I can see the insular ribbon. So, okay, I mean, I'm not be gung-ho or too excited. I think what you want to do a CAT scan is very clearly...
No ICH, sir. No hemorrhage.
No ICH, no subdural. This is a 55-year-old.
Yes, sir.
And
Yes,
no
sir.
major mass effect or greater than 1/3 of MCA. So I think, yes, you could look at a minor, but I think if you look at it, probably I'm not seeing anything, a red
Yes,
flag, lurking around.
Yes, sir.
Next slide. And we got a CT angiogram, which, I think we want to see that there is no large vessel occlusion. You can see the bifurcation on both sides,
Yes, sir.
and then you can see the MCAs.
Yes, sir.
And again, do we know this is anterior circulation? Can you be
Sir, what you
sure
asking?
this is anterior circulation? Is this an anterior circulation stroke?
Okay, sir. Is it is, sir? It's look like the history looks like anterior circulation stroke, sir.
But why could it not be a lesion in the pons, with the sensory symptoms being iffy and, not subjective, and motor weakness? So I think you cannot, unless there is specifically a cortical deficit, a visual field, or on a right side, apraxia or neglect, or on the left side, aphasia. Again, don't put yourself in the box. You're right, less likely, because sensory and motor, less likely in the posterior circulation, but it can be. So you also want to say it's good. I also have the vertebro-basilar system, and the basilar artery looks okay. I can still see the PCA is also being reasonably good. So again, nothing major. And let's look at the DWI. Anything on the DWI?
Yes, sir. In the right caudate, head of the caudate, there is mild subtle diffusion is there, sir.
Okay, all right. Again, I think compared to the other side, I think I would put it, I'm not too impressed. It's not as wide, as I would like to be. And I think you are probably knowing that you're expecting something on the left side. And again, how often do you see a caudate hyperintense lesion, with a left-sided weakness? I mean, a caudate usually, yes, again, it gets the
No.
anterior limb. It
Yes,
usually
sir.
causes more frontal lobish behavior acutely. And again, caudate infarcts are, for all practical purposes, 1 or 2 out of 100. And Dr. Selja can comment.
I would also like to ask you, like, if you have a suspicion like this, there may be some subtle hyperintensity. Always look at the ADC and then make your final impression. Many a time in
Yes, sir.
the diffusion weighted image, you may see some hyperintensity. So here in this situation, even as Dr. Anand has mentioned, I am also not able to see any definite abnormality. But in such situations, when you feel there is a hyperintensity, you can adjust it a bit more and see whether it is still there. And best is to look at the ADC and then decide.
Yes, ma'am.
Can we go to the next slide?
Yeah, sure. And again, I think this is a flare. Again, I think the reason we wanted to put a flare in that, again, not in the context of this case, but sometimes there is a diffusion flare which gets talked about a lot.
Yes,
again, I use the word is a poor man's perfusion, but a lot of time you have to use it. So nothing striking here. As I said, again, if you are in a setup where you don't have anything, get a CAT scan, no bleed. And then the question comes is whether, what do you go ahead? Next slide. What do you do next? So,
sir,
what would you like to do?
I'll give, sir, loading dose of aspirin and clopidogrel 300. Then DAPT dual antiplatelet I'll give, sir, for 21 days. After the single antiplatelet I will want to do.
What about thrombolysis?
Sir, it is actually very minor stroke is there.
Okay. So I think both answers are fairly good. But it is a gray zone area. So let's talk about the pluses and minuses. I think anticoagulation, let's keep it aside. There's no obvious, he's a young guy. There's nothing obvious to suggest that there is atrial fibrillation or a bad MI or anything which could have caused it. So that goes out. You're right. I think it's a gray zone territory. So in favor of thrombolysis, yes, it's a minor stroke. The question is, this gentleman has had 3 recurrent events. And there's a likelihood, that if the weakness persisted, and as of now, he does not have leg weakness, this could be disabling. So whether you put it as disabling or non-disabling. But there was and I'm going to share, a paper from Lancet, which was a meta-analysis of 7, intravenous thrombolysis trials, starting from the NINS to the ECAS trial, the Epithet and Atlantis, which shows in a subgroup analysis for patients with 0 to 4 NIH stroke scale, thrombolysis was better than giving antiplatelet agents for control. But I think your point is well taken. You could argue that there is no large vessel occlusion, and I can go with dual antiplatelet agent. So I think well taken. But again, your comment on dual antiplatelet agent of 300 milligrams and clopidogrel and 300 milligrams of aspirin, we could again debate on the dose. There are 2 clinical trials which were done within 12 and 24 hours. Again, the references are there at the end. And you probably know the trials, as you mentioned. The trials were the CHANCE trial, which was the Chinese study, and then 5 years later, the POINT study. Yes, 21 days. In one trial, you gave up to 3 months, but they used 75 or regular dose of aspirin, not the 300 milligram loading dose. So yes, you could go along with. I can ask Dr. Selja if he went by that option. I'd give a 300 milligrams clopidogrel, but not necessarily 300 milligrams of aspirin. Again, a gray zone. I think if I were not to go for thrombolysis, I think I would definitely like to see that there is no large vessel occlusion. I think you can get by both answers, but with the Lancet meta-analysis, the paper is at the end, you can look up the chart. I think I would favor thrombolysis, though I think read the CHANCE and the POINT study. And then you could also, there was a study done by Pooja Khatri, which was published in JAMA, which was a PRISM study, and where they took non-disabling strokes, NIH stroke scale less than 5, and which showed that the trial was weakly vocal. So it's good. I think you have to weigh. It's not a black and white answer, and I think your answer is acceptable. But you want to look at CHANCE, POINT, PRISM, and the meta-analysis, which is there at the end. Anticoagulation is a no. So, Dr. Selja, any comments?
I would say, like, as it's a debatable thing. We all know that in minor stroke patients, whether to thrombolyze or not is always a debatable issue. I think it has to be taken in an individualized manner. But if you look at the recent European stroke guidelines too, you find that when there is no major vessel occlusion, I may even go for not giving thrombolysis for this patient. One more reason I would say is that the vessels are all normal. You are not seeing any large artery atherosclerosis. You are not seeing any intracranial occlusion in this patient. So I must, and the NIHS2 is just a mild facial with a mild dysarthria. So maybe you can go either way, but in this patient, I would not, I don't think it is disabling and there is no major vessel occlusion. But you can go either way and decide on thrombolysis. And one more thing is when you get stereotyped events like this, in the same territory, and you find that the vessels are all normal, always the thinking process of whether it is a lacunar stroke always comes in. So in these patients also, when you think about giving thrombolysis, always be careful about talking to the relatives very carefully that even after this thrombolysis, we may have had, I am sure all of us have had situations where you thrombolize, then the patient has got another stereotyped event and may become significantly weak too. So we really do not know in these situations. And I totally agree with regard to the dual antiplatelets.
So the question that comes, Dr. Selja, do you want to take it?
Yes. So what is, so do you think it is a stroke? We have confirmed that it is a stroke. So do you think that here the patient has had an NIHS of 2 and patient is having a DWI negative stroke? So what would be the explanations for having a DWI negative stroke? Dr. Bidhan?
Yes, ma'am. Ma'am, pass, ma'am.
Okay, so there are certain situations, even if the patient has got a minor stroke or a TIA, you know that if it is a TIA, only about 40 to 60% of the time, we are talking about the time-based definition. So in the time-based definition, if you take us 24 hours, we know that about 40 to 60% of the time only they tend to become DWI positive. And there are certain factors which decide the DWI positivity. For example, a patient's duration of the event is lasting more than 1 hour. If a patient has got a carotid stenosis, if they have an atrial fibrillation, or in situations when the patient has got a weakness, or a patient has got an aphasia. These are the situations they tend to be DWI positive. When you see a DWI negative, the things which should go through your mind is, one is whether it is, as Dr. Anders already mentioned, at this point of time, we do not know whether it is an anterior or posterior circulation. Posterior circulation, minor stroke and TIA tend to be more diffusion negative. Second situation, there is diffusion negativity is in situations when the patient has got a lacunar stroke. So looking at the vessels being normal and being a diffusion negative, even with an NIHS of 2, with the symptoms lasting, you have to still consider whether it is a possibility of a lacunar stroke needs to be considered. So these are the situations. Then the third situation is whether it is a TIA, the mimic or a stroke mimic. Here we do not consider a mimic in this patient because the patient has got all the risk factors, all the things are fitting in with the TIA or a minor stroke. So how would you want to evaluate this patient? So you have already done a vascular imaging. So how do you plan to evaluate this patient?
Already vascular imaging done, but that aortic arch atheroma that I have to also.
Actually, it's a CT angiogram. We could not carefully see it, but the initial part of it you could see, but the rest of the arch we are not seeing. Very important. It is always important to look for the arch because arch is one of the areas from where we may see atherosclerotic disease, and that may be one reason for a patient developing a stroke. So that is one. Rest of the evaluation, what are the other important evaluation you want to do? You want to get a cardiac evaluation in this patient.
Cardiac
look
evaluation,
for all the risk factors.
Echo will do, and that LFT look for dyslipidemia, yes, and CRP, and
so look at all the risk factors. You do a homocysteine also, and anesthesia will be able to talk long about homocysteine and stroke, and the risk factor evaluation. Then comes the echocardiogram. As you told, echo is done in this patient, and echo is normal. And being a 50s patient in the 50s, the transcranial. Why do you do a transcranial Doppler in this patient? Why do you do a transcranial Doppler in this patient?
To see the intracranial vessel, there is artery to artery, any embolic, microembolic embolism is there or not.
Because we did not see any large artery atherosclerotic disease or carotid disease to suggest a microemboli coming from them. That other than that, what may be the reason? to look for a patent foramen ovale also in this patient. Patient is still in the 55 years with risk factors, but still it would be good to look for a patent foramen ovale and consider the possibility of a paroxysmal patent foramen ovale and a paradoxical embolism.
Yes.
Then Holter, very important. Why is a Holter done in this patient?
Holter can be, it's to see the paroxysmal AF or flutters, any to rule out syncopes also. We can.
Do you want to stop with a 24-hour Holter, or you want to do a prolonged recording in this patient?
Ma'am, this is a very recurrent episode is there. So probably we can get within 24 hours. If we not get 24 hours, then we can repeat again 24 hours. If not, then we can plan for prolonged.
So in this patient, since we have, even though we saw all the vessels are normal, diffusion is negative, considering the patient's age, it will be still worthwhile doing a prolonged recording in this patient to look for paroxysmal AF. Anand, you want to take over?
Yeah, in the context of time, I think, we'll just, is that okay, Dr. Salja? I think a couple of minutes
Yes,
left.
yes.
So likely etiology, no obvious large vessel, less likely to be a cardioembolic, has a good ejection fraction, regional wall motion abnormality is not there. Yes, theoretically possibility of a PFO or in Holter, long-term, as you said, atrial fibrillation is there, but recurrent same side, less likely. So it's a subcortical, small infarct. I think this is most likely the gentleman has hypertension, LDL of 91. Now we target towards 70. So it's most likely a lacunar stroke. I think we could probably get, settled here. If we want, we can go for a prolonged, monitoring for cardiac rhythm. And I think long-term treatment goals, I think we now have to talk in terms of, a month of dual antiplatelet agents. Beyond that, one antiplatelet agent, systolic blood pressure less than 140. Hemoglobin A1C was, I think, 7.3, so less than 7. And LDL now after treat stroke to target, the aim has to be less than 70. So I think those are the things that you do. I forgot whether he's a smoker or not, but I think that needs to be talked about. And next slide. So I think this is, Dr. Salja, do you want to take a take-home message? Or?
No, carry on, Anand.
So I think the take-home message, as I said, 20% of patients who come with ischemic stroke, to us have a history of TIA. So if you can grab them early, you're able to prevent the stroke, which is a permanent deficit. TIA is a medical emergency. Make a decision, act on it, and if possible, admit for a day unless you have a quick workup where you can get things done. Diffusion positive TIAs we talked about, and false negative TIAs in about 6% of the cases. Thrombolysis is a gray zone. This is a classical case. Except if there is a large vessel occlusion or disabling stroke. In every case, we talked about stroke risk factors, LDL, blood pressure, diabetes target, and healthy diet. And I think the last slide, is the references of what we talked about, including the European guidelines that Dr. Salja mentioned, the mild stroke. I think this is for all of you for the reference which you have talked about. So please, I think for all residents, these are good references to read about.
Yes, sir.
And I would also like to add that the most important thing in patients with TIA is a very good history taking, because history is very, very important. Even a syncope or a transient mild feeling of unsteadiness, vertigo, everything is being considered as TIA. So a history taking is very important. Confirm the diagnosis if you are not sure, but still it is better to consider a vascular event if it is of acute onset. Always rule out hypoglycemia and look into the vessels. The vascular imaging is very, very important. Thank you.
Thank you, ma'am.
Well done.
Thank you, sir.
Thank you. Thank you, Dr.
Thank
Salja.
you, Anand.
Yeah, thank you, Rohit. And